Hi, my name is Asha Devereaux, and I'm a pulmonologist in Coronado, California. And I presented a talk on seasonal influenza and COVID-19 to a group of patients a couple of weeks ago, and I'd like to share this with you. The objectives of this presentation is to summarize some of the pathophysiology and epidemiology of influenza, the economic impact, prevention, diagnosis, and management of flu, explain issues associated with some of the resistance to antivirals and why vaccines may not work all the time, some special considerations when treating geriatric, pediatric, and pregnant patients, and describe some of what we know currently about COVID-19 and some mitigation strategies. Why do I want to focus on flu? First is that we've been doing a lot of pandemic planning for flu, and a lot of our strategies and understanding of viruses we can extrapolate to COVID-19, although they are two different viruses. We are currently, as of a week and a half ago, with widespread influenza activity. It is an ongoing public health problem. It causes anywhere from 250,000 to 500,000 deaths annually. 15 million people have already been affected this year, with 8,000 deaths reported as of a month ago. It usually causes about 36,000 deaths in the US, with over 200,000 hospitalizations, costing about $38 billion. Pandemics are an ever-present threat. We can't always measure the impact of influenza directly. However, a useful marker is looking at pneumonia and influenza-like activity. And as is shown year after year, when spikes in pneumonia occur, they are temporally correlated with spikes in influenza activity. Our current season by the CDC week shows that we are on track for having had a pretty significant flu season, and one of the most severe ones that we've had since the 2017 season compared to prior years. In terms of emergency room and visits for respiratory symptoms of cold, fever, or cough, we are seeing a lot more respiratory symptoms than we are seeing just fever and minor URI symptoms. The population of the United States is only graying and getting older, and those over the age of 65 are expected to bear a heavy burden during any influenza epidemic or any pandemic, and they represent a substantial part of our population. In the current season in San Diego, we've seen some deaths in age predominantly in 65 and older, and about 60% have been unvaccinated of all our flu deaths. But fortunately, we're not seeing that many in children yet. If you look at just 1 month apart, influenza A is now taking over as of a week ago, with 18,000 cases, 74 deaths, and significant number of outbreaks compared to just in January with only 7,500 cases reported. It's important to note that in San Diego County there are active influenza surveillance clinics where swabs are being obtained. So that is how this data is obtained. All influenza is still a reportable condition, as well as all deaths attributed to influenza. Proportion of influenza cases by age group this year seems to be affecting those between 18 to 64 years old which is different than prior years. If you can appreciate the columns on top, the age above 65 is one of the smallest from prior history. Influenza in children. While rates of hospitalization are highest among children with underlying health conditions, like asthma or cardiovascular disease or premature birth, it's also high among healthy children during flu season. A 4-year inpatient and outpatient surveillance in three different counties showed that outpatient visits for influenza were higher than hospitalizations. Common symptoms included fever, cough, and runny nose. Of 28% of hospitalization and 17% of outpatient visits were among kids with lab-confirmed influenza, but they weren't, very few of them were diagnosed clinically. And so it's important to keep in mind that when kids present, to have a high index of suspicion, especially if within 2 days of symptoms where we have antiviral treatments. Children are the primary vectors of influenza A spread into the community. They can carry the disease to parents and other caregivers, as well as younger siblings, the elderly, and grandparents, and this can impact morbidity and mortality. If we could immunize children, we may be able to protect our senior population. And this was actually done in Japan. Between 1962 and 1987, school children in Japan were vaccinated for influenza as a public health program. And the dashed lines below are what U.S. pneumonia and influenza rates are at baseline. This program was discontinued in 1987, and as can be shown in this graph, mortality related to influenza as well as all-cause mortality declined significantly in Japan during the years where mandatory vaccine was provided, and then rose substantially after the program was discontinued. Influenza can also impact pregnancy. This study looked at influenza-related morbidity from selected acute cardiopulmonary conditions in pregnant women during a predefined influenza seasons, which were shown in red, compared to the peri-influenza periods shown in blue and the summer months in orange. This is from Tennessee data from a Tennessee Medicaid program for women aged 15 to 44 and who had been seen for at least 180 days. And this is an older study between 1974 and 1993. And it shows that incidence rates of events for women who were considered to have high-risk pregnancies, there was an increase in cardiopulmonary events in the third trimester during flu season and compared to the other times. So in summary, influenza is associated with substantial morbidity and mortality every year. It is recommended that the very young and elderly are at increased risk, and the vaccination will help reduce the impact of flu on society. And the aging of our population is likely to lead to more morbidity and mortality each year. And we need to be cognizant of that. And pregnancy, as well as our kids, are at risk for complications and hospitalizations. So although I'm not a virologist, let's look at just a little brief picture of the virology of flu and how this virus can cause our symptoms. So this is what an influenza A virus looks like. And the influenza B virus lacks this M2 ion channel. Of note, on this outer lipid bilayer membrane of this virus, there are these proteins called neuraminidase and hemagglutinin, which the virus uses to attach to our human host cells. And then within the center of this virus is its RNA replication materials. And these viruses need hosts to then replicate or reproduce. Specific strains of either the type A or type B viruses are further identified by a nomenclature scheme that includes the geographic origin, strain sequence number, and year of isolation. In the case of type A viruses, the subtype identifies the specific type of the hemagglutinin and the neuraminidase surface proteins. Because type B viruses have only one type of the hemagglutinin and one type of the NA, there are no subtypes. Therefore, further numerical designation is not needed. I'd like to thank the Faces of Flu slide deck. It was a CDC program in 2007 for many of these slides that I'm using today, and I apologize for not mentioning it earlier. The pathology of the flu virus has been described previously, and once this virus is inhaled into our nose and airway, upper airway, it attaches to these cells in the back of our throat or in our nasal passages, and the virus sticks to the sialic acid surface on our cells. And then our cells bring it into our system through a process called endocytosis and fusion. And then that allows the virus to penetrate into the engines of our cells. And then the virus uncoats itself in step 3 and then releases its genetic material that then enters our cell's nucleus and then initiates replication. It then packages and buds out and is released. And some inhibitors and medications can impact either some of the fusion that can happen or the one of the residues of the Na particles so that they can't attach. This replication process causes cell death in our mucous lining of the respiratory tract, and then that leads to our symptoms. The virus enters our tract because somebody's coughed and created these respiratory droplets produced by talking, coughing, or sneezing. There's a short incubation period, anywhere from 1 to 4 days, and the virus can be shed actually 1 day prior to our development of symptoms. Infection is usually limited to our upper and lower respiratory tracts and results in cough, runny nose, sore throat, and that's because of the cell death and our inflammatory response to the infection. If the virus has killed a lot of our what we call ciliated cells, that it can prevent clearance of other microbes that invade and then result into secondary bacterial infections. Our immune system starts to try to mount a response by releasing all kinds of mediators and develops kind of an antibody response. And that is found very early, and it coincides with the onset of symptoms. And as these interferons are released, we develop a fever. And then we can get antibodies developed within days of infection, and those peak at about day 10 to 14. The natural course of influenza infection, this was noted in some healthy volunteers, and they noticed that runny nose, sore throat, body aches, headaches, feeling bad, weak, and feeling a sense of weakness occurs very early, and that over the course of the next 5 days, viral shedding occurs, and the nasal congestion and malaise persist into day 7. And this is in an unvaccinated individual. This graph illustrates findings of a case report of a volunteer who was inoculated by nose drops of influenza virus. And they noted onset of symptoms within 18 to 72 hours after the incubation period, a fever to about 100 degrees, and the severity of illness correlated with the virus shedding in this experimental inoculation, and it can continue for 7 to 10 days. And it may actually continue longer in children, and that's what causes an increased risk of transmission of virus. This flowchart provides a visual representation of the course of disease progression, our immune response, and potential complications. In the middle of the slide is how we had described how we can inhale the virus and it replicates in our airways and then it kills some of our cells and it results in our syndrome of fever, cough, runny nose, sore throat. We also develop these mediators and an antibody response which gives us future protection. In the lower part, it shows that secondary bacterial infections, a viral pneumonia, can develop, as well as in children, neurological involvement and muscle involvement like a Guillain-Barré syndrome can occur. There are vaccines for seasonal flu. May not always be perfectly a match because these are made in anticipation of an antigenic drift by groups about a year prior to the flu's arrival, since it takes time to make the vaccine and have it ready for distribution. So sometimes it's not always a match, or the virus itself drifts a bit and mutates within the flu season. But why should we vaccinate? It reduces mortality in the high-risk groups, it reduces morbidity and hospitalizations, and it decreases the economic impact and healthcare costs. A number of studies have compared the impact of vaccination on mortality among a variety of at-risk populations in the community, as well as in long-term care facilities, as well as in high-risk adults like who are immune compromised or chronic health conditions. And those folks even gain a better advantage than our elderly by getting vaccinated. A bunch of trials have shown the economic benefits of vaccination. Among adults under 65, vaccination reduces the number of doctor visits, lost work days, days working with reduced effectiveness called presenteeism, and a reduced need for antibiotics. In addition to impacting influenza mortality, vaccinations have been shown to reduce excess hospitalization in at-risk and community-dwelling populations, as well as decrease risk for all-cause mortality. Two major types of vaccines are currently available, containing a live attenuated virus, and the predominant one is the inactivated virus. There's a trivalent version that covers 3 strains and a quadrivalent version that covers 2 influenza A strains and 2 influenza B. This is usually available in late August, September annually, and these vaccines work by stimulating that antibody formation against the viral surface proteins that I mentioned to you previously. Why do these vaccines have to be renewed annually? Why can't it be just like some of those one-shot deals and we're permanently immune? Well, the flu virus evolves to evade our immunity. They change their NA and the HA surface proteins quite rapidly. And there's an antigenic drift where these small point mutations are normal in their biological processes and create seasonal outbreaks. Now, when these viruses kind of reproduce in an animal host and create a new virus, then we may have a pandemic, and we'll talk about that in a little while. Birds and swine are primarily the mixing vessels for influenza genetic reassortment. So usually waterfowl just circulate avian influenza, and if that gets out into our domestic population, reassort in mammals, and then transmit to humans, we get pandemic potential. There have been some big shifts, and they have been usually avian in nature, and they can cause widespread epidemics. And like the so-called Spanish flu of 1918, which was an H1N1. This year's vaccine composition is A, Brisbane from 2018, A, Kansas from 2017, a B, Colorado from the Victoria lineage, and the quadrivalent also, I think, has the B, Yamagata, in addition to the 2 A's and the B, Colorado above. The target groups for vaccination is children, of course, anybody over age 50, anybody on long-term aspirin therapy, any woman who will be pregnant during the flu season, adults and children with chronic medical conditions, and residents of long-term care facilities. The goal is to have as many people immunized as possible. Groups recommended to receive vaccine to prevent transmission to others include healthcare workers, healthy household contacts and caregivers of children aged 0 to 59 months, or if you're a caregiver, somebody over 50, healthy household contacts and caregivers of anybody at high risk for complications. So basically, everybody should try to be vaccinated. Healthcare workers also in acute and long-term facilities should be vaccinated. And it is now a policy that healthcare workers be mandatorily vaccinated and only opt out for religious or medical reasons. And if they've opted out, that employee must wear a mask when in patient contact during flu season. In the 2018-2019 flu vaccine coverage among healthcare personnel, they were 81% immunized, and it was similar to coverage previously. Physicians of the highest vaccinated group, physicians comprised nearly 97% of vaccinated healthcare workers. Nurses, 98% of nurses were vaccinated, 91% of pharmacists, and 91% of nurse practitioners and PAs. And I should say 96% of physicians were vaccinated. Our peak activity of influenza, which is similar to this month as previously shown, over this year is February. And this, for unprimed individuals, it may take 2 to 3 weeks to develop antibodies to vaccine. But if you've been primed, it may just take a few days to a week to develop an immune response. So it's never too late to get the flu shot, even if you think you've missed it in December and January. So diagnosis and management of flu. Why should we bother diagnosing it if it's flu season? Well, it's very important so that we can prevent spread of disease and transmission to those at risk. If it's flu season and there's a cough and a fever, we would not need antibiotics compared to other times when it could be a bacterial infection. There are some classic signs and symptoms of influenza. Usually feeling like you've been hit by a truck, a fever about 100 degrees, an early non-productive cough, a headache, maybe body aches, chills, sore throat, maybe persistent fatigue. Chest pain, and eye problems are rare but have been reported. The presentation of clinical influenza differs by age group. Cough is more prevalent in adults and the elderly versus children. Fever tends to happen in younger folks. Body aches throughout, but not as much. Headaches. Fatigue tends to affect the elderly versus the young. And runny nose tends to affect the young versus elderly. Factors that affect our symptoms include age, our underlying immune status, our underlying diseases, the viral subtype or strain. Some are more virulent and can make us feel a lot worse. It's also important to note that when flu is active, there are also other viruses circulating at any given time: parainfluenza, respiratory syncytial virus, and adenovirus. However, the seasonality of influenza has been correlated with the temperature, as as shown here by the Wisconsin State Lab, and their number of flu virus isolates increased as their temperature dropped. So it's important for clinicians to know what's in season and circulating in their environment. Out of season, fever, cough, sudden onset is less than 40% likely to be flu, and it could be one of the other viruses I mentioned. In season, fever, cough, and sudden onset of malaise, you have an 80% chance of it being influenza. There are ways we can diagnose influenza by tests and symptoms. If it's within season and you've got classic symptoms, just assume it's flu, because sometimes it's just too hard to get treatment, and you don't want to, or testing, and you don't want to have those folks come into the office and potentially risk infecting others, and treatment may be provided over the phone. There are some rapid tests available, but they may not be as sensitive. A negative test may not necessarily mean you don't have flu. There are some antigen-based tests and PCR, polymerase chain reaction, which is more sensitive, and some are being able to be done within hours. And those are best used when flu is, when you're not certain of the season. Management of flu depends mainly on supportive care and antivirals if caught early enough. Bed rests, chicken soup, analgesics, Tylenol, guaifenesin are important. Avoid aspirin in children due to the risk of Reye syndrome, because it can cause an idiosyncratic neurologic or liver issue. Disease prevention among close contacts. If a person has not been vaccinated, they should be offered the vaccine. Cough etiquette, social distancing, hand hygiene is very important so that you don't pass the virus to others. And if there is somebody that you might expose that's at high risk, but that you're their caregiver or something and you have the flu, make sure that they inform their providers and get perhaps what we call prophylactic treatment, where they can get a medication to help decrease their risk of contracting the disease. It is important for us to be aware of any complications. Here's a great article on chicken soup and how it can help stop the inflammatory cells from propagation. And they used a traditional chicken soup recipe from the 1970s, and they tested it against in a manner to see if these inflammatory cells could be quieted down by chicken soup, because chicken soup is supposed to be soothing and help make us feel better. And they also showed that the chicken broth had some killer activity against viruses or bacteria. So, but that the chicken did not. They also they showed that if you looked at tap water and the positive controls, these inflammatory cells went to town. But if you looked at like Progresso chicken soup or some of the other chicken broths, they had some good activity in suppressing these inflammatory cells. So I thought this was an interesting study. It's not been tested in humans, but it gives some credence to why mom recommended chicken soup. Major complications of influenza virus infection do occur. You can get a primary influenza pneumonia, a secondary bacterial pneumonia, by an organism called strep or Haemophilus or staph. Prevention of institutional outbreaks is very important by vaccination, hand hygiene, surveillance, lab diagnosis, and giving antiviral medicines as what we call prophylaxis ahead of time. Vaccine effectiveness among long-term care facility residents. Age makes a difference in an influenza outbreak. If over the age of 34% had some effectiveness against an influenza outbreak, but those between 65 and 84 had a 46% effectiveness in reducing influenza symptoms and pneumonia. So it's important to note these vaccines aren't perfect, but they do help reduce symptoms in some people. Tamiflu or oseltamivir chemoprophylaxis in long-term care facilities has been done. Once daily use during flu season in a long-term care facility showed a 92% reduction in influenza versus placebo, and it was associated with a significant reduction in secondary complications versus placebo. Use of antiviral. We don't use amantadine or rimantadine as much anymore because of resistance to the that has developed worldwide. So, best data for use in antivirals to treat influenza is when it's given within 48 hours of onset of symptoms, and it does reduce the course of illness by a day, but it gets people back to work quicker. We are getting more and more data on children, elderly, and high-risk populations, and we don't know exactly if giving it later does show benefit, but data is appearing that even at day 3 and 4, it does help reduce the onset of symptoms, and especially in the high risk. Oseltamivir treatment in children reduces the duration of illness compared to placebo by 26%, reduced cough, runny nose, and duration of fever, and decrease in ear infections by 44%. In adults, there was an increase in time to resolution of all flu symptoms by about a day, and an improvement in return to normal activity. And this is in treatment that was initiated within a day and a half of symptoms. The analysis of 10 placebo-controlled trials here shows that oseltamivir showed a statistically significant reduction in antibiotics for lower respiratory infection and antibiotic use, showing therefore that secondary complications were reduced. There are some adverse effects, as I mentioned, with the inhaled version, causes some bronchospasm, and Tamiflu or oseltamivir does have nausea, vomiting, and diarrhea as side effects. And rarely it does exacerbate diabetes and causes psychiatric effects. So that was noted in Japan. There is potential for any of the flu viruses to result in a pandemic, and this model shows how new pandemic influenza viruses can emerge. On the left, avian influenza viruses are shown. These viruses are transmissible to other species of bird, including the domestic fowl. Genetic reassortment can occur within this context and be passed to humans directly, as in the top panel, or it can be passed through a swine when it gets co-infected with two different influenza strains, and then reassorts and is transmitted to humans. If this reassembled virus is easily transmitted from the swine and then proves its capacity to go from human to human transmission, the resultant virus is likely to cause a pandemic, and there would be very little human natural immunity to this new strain. The WHO has pandemic alert stages, and right now, as with COVID-19, we have evidence of significant human-to-human transmission, but there hasn't been a pandemic declared yet. With this novel coronavirus, which is very different from the influenza virus, but I include this lecture because of the respiratory droplet transmission and many similarities in pandemic preparedness and planning. This previously Wuhan coronavirus, or 2019 novel coronavirus, is highly transmissible and is creating quite a pandemic type situation. And by the images above, you can see that the outer rim has this halo-like quality, and with those glycoproteins on top of it, it looks like a crown, and therefore it's been named the coronavirus. COVID-19 is now the new phrase we are using for coronavirus infectious disease 2019. It's globally affected over 90,000 people, and nearly 60 million people in China are in a quarantine lockdown situation in the Wuhan province, where it's believed to have started. Outside in China, over 79,000 cases have been confirmed with over 2,800 deaths. And outside of China, over 7,000 cases have been confirmed with about 100 deaths. In the US, as of today, there have been 103 cases with 6 deaths reported. On February 2nd, there was a mandatory quarantine instituted for people traveling from affected areas of China for a 2-week period, and those folks have been tested, isolated, and many of them have been cleared and released. A travel ban has been imposed by the U.S. to China, with the reconsideration to travel to South Korea, Iran, and northern Italy. In the U.S., our pandemic flu as well as our coronavirus stages are similar. And right now we are in a stage 5 where we have seen human-to-human spread. It's not quite spread throughout the United States, but we shall see shortly. There are 7 different types of coronavirus that infect people. The human genes are the alpha and beta, and then delta and gamma coronaviruses don't affect humans. These viruses are common throughout the world and usually cause mild to moderate disease. 30% of common colds are coronaviruses. The beta coronaviruses seem to be the highly pathogenic and virulent strains, and they caused MERS-CoV and SARS-CoV in the last decade. And those viruses shifted from an animal reservoir and caused severe illness. The animal reservoir for MERS was the dromedary camel, and for SARS was the civet cat. SARS-CoV resulted in 8,000 cases and 800 deaths, and MERS is still prevalent, and an example of which one person traveling to Korea transmitted it to 180 cases, and 30 deaths resulted. So these viruses are pretty significant in terms of their morbidity and mortality, as well as transmission rates. What we're learning about SARS-CoV-2, which is the current coronavirus causing COVID-19, is that it is a distinct clade. It shares about 79% of a genetic sequence with the SARS-CoV that was in 2007, and a 96.2% homology to a bat coronavirus. So they're thinking that that was the animal host, but we don't know if what the other animal that this virus was transmitted in. There was an article just published of the 72,000 cases in China, and what they noticed that they had 44,000 confirmed cases by testing, but they had a hard time with the testing materials and just supplies. So they went on clinical diagnosis and counted folk cases that way as well. This was predominantly a mild disease affecting people over the age of 30. 87% were between 30 and 79 years old. Of the critically ill, it had a 49% mortality. And healthcare workers were at an increased risk for getting infected. There have been some reports on the cases of coronavirus pneumonia, which is what leads to a lot of the morbidity and mortality. Of 99 patients published in the described in this Lancet article, 49% who had developed this pneumonia had exposure to the Huanan seafood market in Wuhan province. The average age of this group was 55 years, 67 were men, 32 were women. They diagnosed this by real-time PCR. 51% had an underlying chronic disease, and for them, chronic disease was high blood pressure or diabetes. The symptoms were fever, fatigue, cough, some shortness of breath, and muscle aches. In severe cases, decrease in renal function, and in some cases, diarrhea, nausea, vomiting were present. Symptoms differ from MERS and SARS based on where this virus attaches. In SARS, the virus attaches to these ACE2 receptors that are mainly in the lower part of our lungs, whereas MERS, the Middle East Respiratory Syndrome coronavirus, attaches to the DPP4 receptor, which is mainly found in our GI tracts and causes more of a GI symptom complex. The clinical characteristics of about 138 hospitalized patients with this coronavirus pneumonia showed that the median age was 56 years, and high blood pressure, diabetes, cardiovascular disease, and malignancy were underlying conditions. They had about 5 days from first symptoms to onset of shortness of breath, 7 days to hospital admit, and then 8 days if they were going to develop adult respiratory distress syndrome. Of the ICU patients, they tended to be a little bit older, 66 years old. They all had underlying illnesses. There were more symptoms of abdominal pain, lightheadedness, dizziness, shortness of breath, and many of them, of the 36 patients, 17 required aggressive life support assistance. It's important to note that 41% of this cohort were exposed in the hospital. 40 were healthcare workers, and 17 of these pneumonia patients were patients that had been in the hospital for another reason and then developed coronavirus. So they were hospital-acquired infections. And these folks' average length of stay was 10 days. This JAMA article shows a picture of the coronavirus pneumonia or pneumonitis with these ground glass changes in the upper row. The blackened areas are healthy lung, and then all the whitish areas are what we describe as ground glass inflammatory changes. In the lower portion is resolution, partial resolution after application of ECMO for 5 days in the intensive care unit. So it shows a significant amount of improvement. But care is supportive, and there are some drug trials actively being pursued in China as well as elsewhere. And vaccine development is on the horizon. However, clinical trials are still need to be run, and this is many months away. So right now, we just have usual ICU care, oxygen, and anything we can do to support all the other organ systems possible, and clinical trials. And that's why containment and prevention is very important. Now, asymptomatic transmission is something that is of concern and has been proven now repeatedly in the US, but the first report was in this New England Journal article dated January 30th. And this one person traveled from China to Germany and attended a business meeting on January 19th. 2 other people at the meeting developed symptoms of coronavirus. This patient, the first patient, had no symptoms at the meeting while in Germany, returned to China, and then developed symptoms and was found to be positive for coronavirus. 2 others at the meeting also developed symptoms about 4 to 5 days later and were found to be positive for coronavirus. Of note, 2 other patients never attended the meeting, but were exposed to people present at the meeting, developed coronavirus infection, and were positive or found to be positive. We don't know exactly how many people get infected from an asymptomatic transmission. And it's currently estimated about 2.68 number of cases one infected person can generate, and then that number would double every 6.4 days. But this is currently an estimate. So it is very important at this time of year for anybody with a cough, now that we're coming out of flu season, but even with flu, to cover your cough with your elbow, cough into Kleenex, wash your hands, throw out that dirty Kleenex, don't keep using it. Frequent hand washing will be very important so you don't shake hands and then touch your face and receive the virus by this respiratory droplet. You can see by this pictorial where powder was kind of flashed onto a person who had just coughed, how much the respiratory droplets can be produced after a cough or a single sneeze. It's important to stay about 6 feet away from anybody coughing and sneezing and not to share any personal items. And now more importantly so because of this COVID-19. Back in 2007 and 2014, I was part of a great group of people that helped think about what to do in the intensive care units in preparation for pandemics or disasters. Of that group, Dr. Louis Rubinson, is extremely profound, and had a blog posted on January 30th for the Society of Critical Care Medicine regarding that we should not ignore even small index cases because of human-to-human transmission can of this type of an illness can create a very significant population health burden, as was proven by SARS in 2002 and 2004. In a 21-hour period of an unrecognized exposure in a hospital, it led to 128 cases and spread to 2 other hospitals, and because 2 ICU patients were transferred. So this is a serious thing that can affect healthcare workers as well. And it's important for healthcare systems to keep their employees safe and working so they can take care of folks. It's important for systems to ensure inclusivity and transparency in order to avoid mistrust. Our knowledge is rapidly evolving on COVID-19, and there's a lot of misinformation out there. Recognizing a patient, isolating them, and wearing appropriate protection is paramount. Using electronic communication as much as possible. Ways for the healthcare system to recognize these folks would be to obtain a travel history, but at this time, any respiratory infection with a fever should now be suspect, in my opinion. It's important for hospitals to consider staff, supplies, space, the skill set of employees working in this under these conditions is very important. Safety is going to be paramount, and response teams will need to be dedicated to helping those who are clinically affected by COVID-19. On a personal level, if you think you've been exposed and you have a fever and a cough, avoid going to the doctor's office. Call your doctor and ask them what you should do. If your symptoms are severe, go to an emergency room that is capable of isolating you and testing you. Try not to go someplace that won't be prepared for you, as you put that institution as well as patients there at risk. Rest, fluids, analgesic, cough medicines, isolating yourself from other family members, and good hand hygiene will be very important to reduce transmission of this virus as well as permit your recovery. As noted in the China experience, 81% were of mild cases. If you are fairly stable and healthy, you can anticipate being under home quarantine for about 2 weeks. Masks, they're a big deal right now. They may make you feel like you're protected, but the coronavirus can enter via the eyes or any exposed nasal or oral mucosa. Healthcare workers are exposed to higher concentrations of virus and currently require the mask supply, especially the N95 masks, which are protective. Simple face masks do not provide protection because the virus can enter. But if you are sick and coughing, it will decrease the transmission of all those respiratory droplets to other people. So it's important, if you have a cough, to try to put that mask on so that you don't infect other people, and try to get away from them. It is better to perform social distancing, wash hands with soap and water, and avoid the crowds, which is what I had alluded to previously. There's a lot out there on pandemic preparedness on state, local, and global websites such as the WHO and CDC. The State Department has been posting travel restrictions and considerations to keep in mind with your travel. And there are many online resources, including the publication of documents that I had mentioned to you by the American College of Chest Physicians. I thank you very much for your attention, and please be safe.